This conference will now be recorded.
So good evening, gents, and hope your holiday getting off to a good start. I want to read our disclaimers and information here. AnCan is grateful to the following sponsors for making the recording possible: Bayer Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics, and all the generous donors who have attended these sessions. AnCan respectfully notes that it does not accept sponsored promotions for any drugs, protocols, or devices that are recommended in our discussions. These are solely based on anecdotal peer experience and the clinical evidence that we get from published research articles. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear in the sessions with your own medical team. And then if you have not yet completed the survey, it would be most helpful if you click on the little chat window up above and copy the link that's in there and take the 5 or 10 minutes time to hit
This
it.
conference will now be recorded.
Okay. Hopefully it still has the other part. Cosley, how are you this evening, and are you going to need some time?
I'm well, sir, and I do not need any time. Hi, guys. How's everyone doing?
Hi,
So
Cosley.
I want to take just a minute to thank Cosley and Boykin, who are on top of our sessions here so that the recordings get posted. And if you miss something and want to come back, you have the ability to do that. So thank you, guys. That's very helpful. We're seeing, our 20 or so people who attend these sessions, but we also have 100 to 200 people who are going to come in afterwards and look through the sessions. So they're online, they're on the AnCan website, and you can go ahead and direct friends to that if they would like more information. Paul wanted to check in with you. Are you going to need some time tonight?
Sorry, I'm on mute. Just listening in, that's all.
Okay, that's great. Thank you. So let me get started here with Sherelle. What we normally like to do is I have a questionnaire, and it allows us to get if I run through this and get these information, and then we can open it up to the group to give you feedback on your situation and let you ask any questions to the people here in the group. So first off, can we get how old you are? Let's see, Sherelle, you have to unmute the phone. Let's see if I can do that. No, I can't.
Maybe he stepped away from his phone.
Yeah, he may have. Let's take a second here and go ahead to John S. You are up now, and we'll come back to Sherelle in a bit.
Yeah, just 3 weeks out from Dr. Nagar's radiation, 5 sessions, pretty minimal side effects. So I'm pretty happy with my choice so far. So, yeah, no bowel issues, which I thought I would have, but everything's going pretty good. So I thank you, Dr. Mark, or Mark, as so.
Well, our goal here, and I think for all of us, is to have a nice, boring prostate experience, and then share the boredom with other people.
Yeah, because I was lost when you found me on Facebook. So thank you.
Well, you are most welcome, and I'm glad that things have worked out well. Had someone here last week who was in town from North Carolina who decided to come to UCLA. And while the scheduling thing and the time zone played havoc on his bowels, getting them adjusted for the time. Um, the experience was over and done without complications. So that was nice to see.
Yeah, I read that.
Any questions for the group, or can you share with us? One question that I have is, can you share with us what the long-term follow-up plan is?
You're asking me?
Yeah, John.
Yeah, I just gonna see Dr. Nagar on March 5th, I believe, just for PSA, and you know, we go from there.
Okay. And does he say anything about repeated biopsies or MRIs?
No, he never mentioned it. So,
Okay.
I
Well,
mean,
that's
I guess I'll find out. Last thing I want to do is another biopsy. So,
okay. That's fine. Any questions for John from anybody?
Yes,
Yeah,
Go ahead.
John, what
yeah.
what was your treatment?
The Unity Electra 5-session SBRT.
Oh, okay.
Yeah, I was basically I was in a tube for less than a half an hour each time. So, evidently, I didn't move, nor did my organs move. So, you know,
John, do you know how many gray
yeah,
they?
40.
So that's the difference between what you went through and what Stuart went through. You did the retire study, and I think that was 36 and a half gray. Was that correct?
He,
It was for me.
Yeah.
Dr. Nagar said 80%. We were 80%, so what's the 80% of 40?
Well, I hope they have enough patients in this study, because I think it's important that people realize that the retire study is using irreversible electrical puration at the site of the lesion, and then a lower dose radiation to the whole gland. And the idea is, will this um, lower the side effects? The radiation alone at that dose probably is effective, but may have a higher recurrence rate. So combining radiation and the IRE probably is a lot better than the focal treatment alone. So it'll be interesting to see if they have enough patients to show that this is going to reduce side effects. I'm excited to see those results.
The other thing,
Sorry.
John, you did the MRI guided machine with Dr. Nagar, right?
Yes, yes.
Okay. And can you tell what was your what was your Gleason score? Just a rough background,
Well,
just to get an
I was
idea.
a Gleason 7 originally. It was 4-3 and 3-4 and 2 cores, and that was fairly small. I think 1.8 and I forget. And I had 3 other cores, Gleason 6, 3+3. So I had too much. I had 30. Then I went to Sloan. Make a long story short, I went back to Sloan. I went to Sloan because my local urologist, forget it, he had me as stage 4, and they wanted to put me on 3 years ADT. So I says, the hell with this, I'm going to Sloan. So I ended up with Dr. Nagar, and the cipher test came in low. And make a long story short, they downgraded me to 3-4, but I had 35% 4 in one core and 20% the other core. So that kind of put me over the top for active surveillance. And because I had a low SUV update, and one of my pelvic nodes was only 2.6, Dr. Nagar feels it was a false positive. So I decided not to take a chance. I went for treatment. So no ADT, and I just wanted to avoid ADT at all costs.
So no hormone therapy, just the radiation.
Yeah.
Okay,
I don't
okay.
want to wait and risk something escaping. I had some perineal invasion, and one of the tumors was up against the abutted the capsule. So I guess all those reasons I decided to go forward.
And I'm curious whether they irradiated that node that may
No,
or probably was not. Okay.
no, he decided he was very, because of my low decipher, he just thought it was a false positive. It was only
Yeah.
2.6, and the tumors were fairly small. I think 1.8, and I forget. So no, Dr. Nagar was just confident and just totally positive. So
It's my understanding that the field size with both Unity and the Meridian is such that it wouldn't be one pass on it. So I think it would be twice as long to pick up that one node. And you'd still be able to come back if the PSA were still up, or at some point you needed to treat it. There's not a problem treating it at that point. But I think the issue with that machine is that the field doesn't go out wide enough to cover both areas of lymph nodes and the prostate.
yeah, the other thing I found interesting is I thought I would have to have a semi-full bladder, but they told me empty bladder was fine, which I guess they have the latest imaging software, as you stated. So yeah, I didn't even have to fill my bladder; it was actually empty. So
Tim and Stuart, did they give you any guidance about bladder and bowel on your program and protocol?
Yes. Full bladder, empty bowel.
And Stuart, did you?
My same as John. Empty bladder, empty bowel.
Empty
that's
bladder.
empty.
Okay.
Yeah.
That UCLA last week, not as part of the study, the fellow was told, Don Williamson was his name, he was told, again, full bladder, empty bowel, and he had a little holdup because of gas in the rectum until that passed. You never really understand prostate cancer until you're lying on a table with a bunch of radiation technologists there who are telling you, "Can you pass gas for me?" I mean, it's not something my wife ever told me, so I have no experience with something like that.
Just for information, I had SPRT about 8 years back under the clinical trial PACE, PACE, and I just had the SPRT, no other treatment. At that time, it was they used to put 5 markers, gold beads, into your prostate before doing the radiation. It is about 8 years now. I was 72 years when I took the treatment. Now I'm 80. It was taken in Sunnybrook, Toronto, Oddity Cancer Center. And after 8 years, I am more or less all right. I'm quite active. I play some golf, tennis. Uh, and my last PSA rating was 0.08, just for information.
So with the older machines, you have to do the gold seeds. With
Yeah.
Meridian, which John Stewart and Tim underwent with the MRI linear accelerator, you're able to avoid having the seeds placed. It's interesting because it's about 50-50 on whether they put a gel in, a SpaceOAR or Barrigel to protect the rectum. And I'm sure it also depends on where the lesion is in the prostate as to whether that's advised.
And I
Yeah,
also had
I opted out, Mark, as you know. So Dr. Nagar said, no, you don't need it. So
Right. He's not one for doing that. I know that Dr. Matt Roach does not. I know Dr. Kishan does half the time. So, I mean, I think it's something that it's not totally decided clearly as to which patients would benefit.
I was also
Have any comments? I'm sorry.
and I was also told the gel was not required. and I had 5 treatment of 8 gray, totaling to 40 gray.
Okay. And any other comments for John before we move on? Okay, let's go to Enrico. What's going on?
I'm basically 2 months behind John. I'm a 4.3, Gleason score 7. I also tested negative or low on the Decipher genome test. And I'm going with Dr. Nagar, and I'm scheduled to start treatment in about 3 weeks. And I'm going to be doing the MRI guided 5 sessions, 1 hour, every other day. But he did actually schedule me to get a spacer inserted. So, so that's, and I didn't ask. He just said, this is what we're going to do. We're going to do the 5 treatments. We got to schedule for the spacer injection, and then we got to schedule for the imaging, the pre-test, I guess, before the MRI. And then we'll get you going sometime late February. Is kind of the plan. I opted out of the ADT. So right now, based on what Dr. Nagar said, he said if just with the treatment, the radiation, I'm about 85% chance of cancer-free after 10 years. And if I do the ADT, it increases it another 4 to 5%, so it gets me up to 90%. But you have 6 months plus recovery side effects associated with it. And for me, I decided the risk reward is not there for that marginal increase, particularly since, and Dr. Naga agreed that with the low Decipher test, it gives you more confidence in doing it without the ADT. But clearly, the more conservative approach is to do the ADT, but I've decided I've opted out of that. So that's kind of the plan, and I'll start, like I said, kind of beginning of February is when the process starts, and then, however long the 5 sessions take.
Okay. Is Dr. Nagar going to insert the SpaceOAR? Is they have a urologist do that, or?
That's a great question. I literally, so I met with him on Friday, and he basically, I told him I decided radiation is what I wanted to do. And he said, okay, we talked. He's like, okay, this is the plan. This is what we're going to do. And then we got to schedule the spacer. And I just literally got an email from the institution saying you've been scheduled for this day. And that's it. That's all I know as of now. I will be having a call with the nurse practitioner who's going to kind of walk me through everything, and that's definitely going to be a question I'm going to ask on who's doing the spacer.
Another one I might ask is do they ever use Barrigel versus the SpaceOAR? These are 2 gels. Barrigel is getting a pen.
Yep. Okay.
Okay. Barrigel.
Barrigel?
Yeah, Barrigel. It is easier to insert and spread. It takes a little longer to form. So as such, it's thought that there may be a lower risk of side effects from it, and more uniform spread, so you have more even protection of the rectum. You might want to ask what what are the side effects if I don't do this? How likely am I to have side effects from radiation versus what are the side effects from using a gel? And they're rare, they're 1% or less, but those side effects can be significant with the gel. So make sure you understand that, and it's not just how to come in and how to prepare yourself, but what are the risks and benefits.
Okay, that's great. Thanks for mentioning that, because I didn't realize there were really any kind of risks associated with it, and I assumed because I know when last time I was on this, you had mentioned that he generally does not use it. So
yeah,
the other question I'll probably ask is just like why, since I've heard that in the past in other patients he doesn't use it, why is he recommending it for me?
right,
so,
exactly. Yeah.
Could I comment on that, Mark? Yeah, it's protocol to, I guess, for insurance liability purposes to go with it. And then if you could question him on it. He does do the SpaceOAR. The Barrigel is also offered, and a BioProtect balloon at MSK is also offered. So just want to chime in. I mean, you could question him. He was very confident with me. He said, "No, you don't need it." So, you know.
I think the way to ask it is, what are the risks and what are the benefits of using and doing a procedure? I think if you ask a physician, as John may, you may have suggested there, if you ask, should I or would you, they may be more likely to push for the test getting done. I never wanted to tell a patient a risk and then tell them, oh, that won't happen to them, or we don't need to do that if they ask. So that's just a normal everyday bias. And I'd much rather tell you what are the benefits that you get. And if it's a 1% risk of side effects, but a 10% reduction in the risk of a side effect from the radiation, then it makes sense. If it's a 2% improvement in reduction in side effects and a 1% reduction, I probably wouldn't choose doing it. So that's the kind of question to ask, as opposed to should I.
That's great information. Thank you. And so to my understanding, then, so Barrigel is one of the things, and then SpaceOAR is a different one. It's a different
SpaceOAR was the first gel, and the difference is that SpaceOAR hardens or forms very quickly. In fact, sometimes they don't even get it all out of the needle before it clogs up and forms a solid barrier, and they can't get all of it in. Some of it has to do with our anatomy. Some of it has to do with the skill of the doc. But there was one guy who was on, actually from the Tampa area, Tim, who went to Jacksonville and got the SpaceOAR gel, and it was injected into the wall of the rectum. And he had some very significant issues with it afterwards. So you don't want to be the first one for the student to do it, if you're going to have it done, whether it's Barrigel, SpaceOAR, or balloon. But I think the balloon and the Barrigel may be more advanced and have a little greater cushion of safety.
The balloon, you said that's the third one? Okay.
Yes, it's called BioProtect.
BioProtect. Okay. And what's your, just in general, your just your take on it? Like, is it something that you think it makes sense to do? Is like it's an extra level of protection, or are you like you're kind of like indifferent to it?
So I did not have it. It was not an option when I went through with the radiation. And I went through with MRI Linac, and I did not have any side effects. That said, I think this is enough nuanced that it's best decided by the person who's looking at your MRI and doing the planning and knows what is the dose to the rectum and how close is the prostate. So if the prostate is sitting right up against the rectum and the lesion is towards the back of the prostate, then I'd be more prone to do this.
My lesion's on the right side. Is that the back?
No, that's on the right side, but it can be forward or anterior.
Oh, it could be in the back. I got you.
Yeah.
Okay.
But I think that's the kind of thing that we have to rely on our radiation oncologists and get to a good one who has a lot of experience, both in terms of seeing the complications and seeing a reduction in that. And that's not us here.
Yeah, fair enough. I mean, listen, I think Dr. Nagar is at the top of his field. So if he tells me he recommends it, I have no reason to say no. I don't know anything about this stuff. He says I should do it.
I agree entirely on that.
Okay. Okay, but like, yes, definitely ask who's going to be doing it. So that's another very valid point. Thank you for that too.
The other thing is, you're in New York City, and how would you travel to the facility? Do they have a space if you need to do a fleets and empty your bowels? Will they have a room for you to go to do that? Or are you supposed to do this at home? how aggressive are they in bowel cleaning?
Well, yeah, I don't even know what the procedures or recommendations are or anything like that. So I'll find that out. But I live 15 minutes away from where all this is happening.
Okay.
So
Mark,
so
Mark,
it's
could
not
I
a problem.
comment on that?
Yeah, go
During my
ahead.
simulation, I did it at home. It was fine. But my first treatment, they popped me out of the machine because I did it at home for my first treatment. And they said, well, you still have some, try to evacuate. If not, we're going to give you fleet
Yeah.
again. So the recommendation is let the nurse do it. It's no big deal. You just make believe you're on a date, and she comes in and she does her thing, and you finish up. So, yeah, it's best to do it at the hospital. So let them do it.
And
No big deal.
the foam just dissolves over time on its own. Is that correct?
We're talking about the fleet.
Yes.
And
Yeah, no, I know that. No, but I'm saying I went back to the foam. So the foam
The gel.
sorry, the gel. Yeah, sorry, the gel just basically over time dissolves on its own. Is that correct?
Yeah. I mean, the main thing would be some fullness or a sense that you might have to go to the bathroom a bit more, and then you adjust to that, and it starts dissolving over that time frame.
And what time frame does it dissolve usually? I mean, we're talking months or weeks or days.
I think it's about 6 weeks.
Okay,
That's
so short
her.
time. I guess. Okay.
Yeah, it's a short time, and I know that you would not be uncomfortable the whole time, but initially there could be a sensation that, I got to go to the bathroom and nothing comes out, or you don't have anything to do.
Gotcha.
So, let's see here. John, you had your, you
yeah, I
spoke.
had raised it before, but Mark, I'm just glad we helped you make a decision. I know you were real nervous a couple of sessions ago, so I'm glad you're moving forward. Enrique,
Okay.
I'm sorry, Enrique.
Yeah, Enrico. Yeah, I'm making no decisions.
Yeah.
Yeah.
Yeah, no, I tell you what, it's funny because I was on here, was it 2 sessions or 3 sessions ago? I had just kind of gotten the diagnosis and I was just trying to figure out what to do. And, most surgeons were telling me to get surgery and I was freaking out a little bit. And, this whole session was very helpful and just kind of getting some basic facts on, what to do and how to approach it. And just having the decision done now is just like 99% of the stress is gone now. Now it's just like, all right, I'm in Dr. Nagar's hands. I'll let him do what he does best. And now I can just basically go through the motions. And so that's this whole process here has been very, very helpful. So thank you for everybody. That's it's really helped kind of like fundamentally kind of structure how I'm supposed to approach it and how I get my information. And it just helped a lot in making a decision. So thanks to everybody here.
Thanks for those feedback, and we would appreciate. Earlier, I posted in the chat window a link to an AnCan survey, which allows us to gather feedback so that we can make sure we're doing the best job we can for you. And then also, as the next step, when you're done with us, I think for most of us at this low intermediate stage, the decision is far worse than the treatment, and we should help other people get the kind of support and make sure that they're getting full informed consent, because it's just, I mean, that's the greatest thing, unfortunately, is the myths surrounding prostate cancer, and the incomplete information that guys get. So hopefully we can do a better job. Sherelle, are you there? I don't know if that's caller 4 or caller. Identify yourself. I know we have Henry here. Anybody else calling in on the phone? Okay. Lewis, are you going to want some time? Lewis.
Sorry, I was on mute. No, I'm just listening in today. I still have meetings to take place and just still in the learning process. So listening intently.
Okay, John, do you have some comments for state of the art in the prostate world, since we have run through our list here? It's an early night.
On me, John?
Yes, you, John.
State of the art in the prostate world. Well, what I appreciate, Mark, is that you know all these machines. In fact, just to tell the rest of you guys, I wrote to Mark a little while ago because I have a friend about to get radiation therapy. She's not going to for breast cancer. She's not going to major centers of excellence or NCCN facilities. So I got a list of all their machines and sent it to Mark because it was all Greek to me. So I love the way that we are getting directed to the best possible machines, best possible technology. We've recently taken up an issue about this with an article, following up with an article in the Journal of American Medical Association, identifying the fact that a great many people, when they start treatment, are getting treatment that is old-fashioned and inadequate, and really, because they're metastatic in these cases, they need to have a second drug added. So
Hello?
we're trying to keep things up there. Yeah, who's on the phone?
This is Sherelle. Can you hear me?
Oh, you're back again, Sherelle.
Oh,
Okay.
good. Well,
We can hear you.
yeah, that'd be great. John, do you want to finish, and then we'll go with you, Sherelle?
I think that was about it. Most of the stuff I work on is in the high risk area and wouldn't really be of value to this group. So I think I'll just stop there.
But I think that, you know, a lot of the people who get to the high risk, a lot of them are people who were destined, either showed up initially as being high risk or showed up earlier and had inadequate treatment or
Yeah.
wrong treatment, or those with side effects really were in the best situation possible. And I think that it behooves us all to make sure that we're at a center of excellence. And even the center of excellences don't always function as a multidisciplinary team. So while you go to a place that may be known as a cancer center, you want to make sure that all the people meet, the cases are shared amongst the different specialties to get input, rather than someone who just goes off and that's the only treatment they have and that's the only thing they offer, and that's what you're going to be told you should do. That's not necessarily the best approach. So we do have our work cut out for us. I would hope that in the near future, there may be better guidance from AI to allow community physicians to understand when they are the best person to manage something, or when the person ought to be off at a major center.
Mm-hmm.
And the other thing I would just add, just in my experience, so I ended up meeting with like 11 different types of urologists, from, you know, radiation to surgeons to whatnot, to get the kind of like the best information. And I was amazed at how the data that gets shown to you basically gets skewed based on what their specialty is and, you know, what their bread and butter is. And it was actually mind boggling that it was so, like, they're looking at the same data, or they're cherry picking whichever tests they want to, you know, or studies they want to show you to basically justify why surgery is better. And I think the radiation people do it less. And I don't know if it's because maybe they're just getting inundated with business because most people are deciding to do radiation. But I found with surgeons, it was very, very, very one-sided, and it was all just justify surgery. And it was pretty surprised by how different it was. And you're at the same hospital talking to a surgeon versus the radiation expert, and the radiation guy's like, no, that data is meaningless. It's not really relevant anymore. So it was pretty eye-opening. So, like, the one thing I learned is, like, just meet as many doctors as you can and get as much information as you can, because each doctor has their own biases, and they're going to skew things based on those biases.
What Enrico just described is precisely my experience also.
You know, when I was in training, we would have weekly cancer conferences. And as the lowest person on the totem pole, it was my job to find patients to present. And each of us on the team would present a new patient. And then you would have people from all the specialties in the room sitting there. And at the tumor board, we'd have pathologists who would show biopsies. We'd have the radiation oncologist or the radiation radiologist reviewing the slides of any films. Actually, at that point, they were picking up the films and showing it before everything was projected and electronic. So that was a wonderful approach, and I think it helped avoid some of this one-sided exaggeration, which often happens. Okay, let's move on to Sherelle. If it's possible, what I would like to do is I have a form that helps me get the basic information, and then we can throw it open to discussion, if that's all right with you.
Yes, that's fine with me, Mark.
Okay, how old are you?
I'm 54.
Okay, and where in Alabama?
I'm in Montgomery, Alabama.
Okay, and how were you diagnosed?
I was diagnosed in October as a result of a biopsy. October of this year, but my journey started in 2020 when my primary physician sent me to a urologist because my PSA was elevated in my annual physical.
Okay.
Had my first biopsy, first MRI, and then based on that MRI, the urologist recommended a biopsy. That was in 2022. That one came back negative. Continued on with elevated PSA. So in 2023, did the MRI again, as well as a 4K test, and then another biopsy. That one came back negative as well. 2024, continued with elevated PSA, another MRI, then the biopsy in October, which came back positive with a Gleason of 3+4. One bit of information I do not have, which a question I need to go and ask, and this biopsy was conducted at UAB in Birmingham, Alabama. I do not know the size or the location of the cancer, so I know that's a follow-up question that I need to ask, which I've learned from this group.
How many cores, how many biopsies did they do, and how many were positive?
I've had 3 biopsies, and 1 was positive in October of this year. That was the one that was positive.
Okay, and do you know the %for in that biopsy?
No, sir, I do not, and that's a question that I need to ask. So, what's that term again, Mark?
The percent of number 4 in that biopsy core. And I imagine they did MRI fusion on the biopsy. Did they see lesions on the MRI to help them target where to do the biopsy?
Yes, sir. Yes, they did.
Okay. And was it a transperineal or transrectal biopsy?
All of my biopsies have been transrectal.
Okay. And do you know if they've gotten a second opinion on the pathology?
I do not know that, Mark, but I want to go to a center of excellence and get a second opinion.
Okay. Let's see. You haven't had a PET scan? And want to
No, sir, but I do have one coming up. They offered for me to be a part of a Lancet trial where I'll get a scan, and they're doing a study. It says the purpose of the study is to learn whether Pilafra PET imaging can safely and accurately detect the presence or absence of prostate cancer growing beyond the prostate gland in men with favorable intermediate risk prostate cancer. So I have that PET scan scheduled for January the 15th.
And how high was your PSA?
My last PSA was 14.32 in June of 2024.
Okay, so that puts you actually into the unfavorable intermediate because of the PSA above 10, which doesn't really change a whole lot, but it would, if that were a lot lower, they might, and it's a low volume of cancer, they may discuss active surveillance. But with a high PSA in that, I'm not sure that would be an appropriate thing to ask about, or it's appropriate to ask, but I'm not sure that would be best consideration.
Mark,
Go on.
Sir, that's a great point. Thank you for that, because at this diagnosis, they gave me 4 options to consider for treatment. They gave me active surveillance, focal therapy, surgery, and radiation.
Well, that's the whole ballywick. Share my biases with you. But there's one other one that both Stuart has done, and Tim, I think you did the retire study as well. Oh, no, John S. did the retire study, and Stuart did that. And that's a study where they use focal at the lesion that they see, and then treat the rest of the gland with radiation. I think the elevated PSA would throw you into the unfavorable intermediate. And that's a label. I don't know that that has anything to do with prognosis per se at this point. But I'd want to, first off, get another reading on the slides. And the 2 places to set that or to arrange that would either be through Johns Hopkins, and that's something you're going to have to look up and arrange yourself. There are instructions on the website how to do that. The other is Dr. Ming Zhou, Mingzhou, and he is at Mount Sinai in New York. And what they would do is send the block off and confirm the biopsy, because that's going to be important in your case. But I think with an unfavorable intermediate, active surveillance probably isn't the way to go. The other thing I would say, and this is my bias, while people choose surgery, and they'll tell you because of your age that young men do better with surgery, but whenever you say someone is better, they ought to say better than what? And young men will certainly do better than an older man. If you have someone who's 75 or 80, they're not going to tolerate the surgery well, and they won't likely do well. The younger man will tolerate the surgery better, but side effects can occur whether you're young and old. And at 54, if you develop impotence and you develop incontinence, and you could be looking at the next 40 years dealing with incontinence and ED. All of those things can happen with radiation, but they are less likely and they're not immediate. The incontinence is very rare with radiation. Again, done well. I think in your situation, it would behoove you to find a National Cancer Center, NCCN, Center of Excellence that focuses on GU cancers. And that might be at MD Anderson, and I'm going to ask Rick to get us a name there. And then also at Moffitt. And at Moffitt, I might recommend Dr. Johnstone in radiation oncology there to speak with him. In New York, there's a clinical trial called the RETIRE trial. And in that study, again, they treat the local lesions that they see on the MRI and then wipe up any disease in the rest of the prostate. Doing that kind of radiation, either the 5-day SBRT with the state-of-the-art machines or the RETIRE study, it's pretty easy. There's almost no recovery or minimal recovery from it versus surgery, where it's surgery and you're going to wear a catheter for a while, and then you may have urinary difficulty after. So in someone with early disease, as your situation, I'd be careful about considering surgery and not getting pushed to that. So
Yes, sir.
let's go on.
No, so thank you for that, Mark.
Yep. Rick, do you want to offer any comments or referral sources at MD Anderson? I'm not familiar with the docs there that he might look to potentially in radiation therapy or to make decisions.
Where does this gent live? First of all, what's his name? Let's put it. Can we put a name in?
It's Sherelle. He's 54 years old. He's had multiple biopsies. The last one had a 3+4, a single core out of 3, but he's had PSA at 14.3 now. So we mentioned already getting the second opinions on the path.
Well, I think I probably would start with a good urologist. That would be. And where do you live, Sherelle?
I live in Montgomery, Alabama. I'm going to UAB in Birmingham, Alabama for my urologist, but I am willing to travel.
Actually, UAB, I'm pretty sure is a center of excellence.
Yes, it is.
And the question really is what you have to come to a decision as to whether you want to follow the road of surgery or radiation, or if you're in a position to do active surveillance. I'm sorry, I'm trying to do two things at once. What did you say, Mark? What did you say the disease demographics were?
Hold on. Hold on a minute. I'm being both ends here.
Okay.
Matt is away and he went shopping and he's coming back. Okay, sorry about that. What was your question, Rick?
3+4 and how many cores positive?
3+4, 1 out of 3 cores.
One out of 3 cores.
Yes, that's multiple biopsies this was your third or fourth biopsy. Sherelle. Third biopsy.
And how much but the PSA is now risen to 14, correct?
Yes.
Correct.
So really what you need is you probably need a second opinion on your UAB urologist. And the question is where to get that second opinion. I really don't, because I'm not so good on the urologists. I'm very good on I'm fair on the radiation oncologist, very good on the GU medical oncologist, but I'm not sure where I would send you.
I'm wondering.
You
I'm
know
wondering if
what?
Tim, sorry.
Go ahead.
I'm wondering if Tim has a name in Tampa, which is relatively close, of a good person to kind of get you pointed in the right direction.
For urology?
For a second opinion.
Oh, on the pathology, I got Ming Zhao.
No, not on the treatment choice. I have an idea for you, Sherelle. Normally, we don't send people to GU medical oncologists for guidance unless it's a very sticky situation. But I might make an exception. Let me ask Dr. John here. Dr. John, do you think that we should send Sherelle over to Dr. E for some navigation? What do you think?
I have no doubt that she could give us a very up-to-date and thoughtful opinion about the questions. I don't know if would you be able to get in with this history? She may be used to seeing people with much more advanced disease. There may not be room considering all the traveling that she does, but if you did, it would be great.
Yeah.
And I would, if there's is there an excellent, is there a GU medical oncology division in a center of excellence in at UAB? Did you say?
I think there is. I think I've seen them do some research. There's some research that's come out of UAB that I've noted recently, but none of those docs really stand in mind. And you know, I would say that you want to get yourself to probably a urologist who is not necessarily who favors active surveillance, who isn't a cutter. I don't have the right now. I have the name of somebody who's really who I could recommend at Sylvester in Miami. Is that because we've had good experience with him and we know he favors he favors active surveillance. How would you feel about going to see somebody at Sylvester Cancer Center in Miami?
I can do it.
Well, I like this.
Clausen in Atlanta would also be. I mean, if distance doesn't bother you at all, Clausen is a urologist, but he's a urologist that specializes in prostate cancer. He's in Atlanta.
Who is that? I'm not familiar with that person, John.
Klaasen, I think it is. Clausen.
And do you know where he practices?
In Atlanta, but I forgot his exact. He would be extremely knowledgeable, I think, about this.
Yeah, he wasn't he one of the authors on with Shore? Wasn't he the one on the author with Shore on that editorial?
Yeah, Zachary, I think it is Clausen.
Yeah, and he's often on. He does a lot of work with the Prostate Cancer Foundation as well. Let me just see. I can't remember. I also can't remember off the top of my head where he practices.
And if you have LA ties, there's always Mark Scholes. And that's what I did, was get on a plane from Atlanta, 6:30 flight, and had an 11:30 appointment with Dr. Scholes here in LA, and then head back to Atlanta later that afternoon.
Okay.
I think also the PET scan is going to be important if they're doing that study. that will be valuable for you. But I also think the things that are going to be important at first would be to get that a second opinion, send off an order, Google both of the Johns Hopkins pathology and Dr. Ming Zhao, and you'll find instructions on how to arrange for the second opinion on the pathology. I think that and the PET scan are going to be important before you make any decisions.
Okay, sounds good, gentlemen.
And then Rick will post in the chat in a few minutes the link to the PROMISE study. And the PROMISE study is great in that it checks for, I think it's 29 different mutations that could affect how the prostate cancer would potentially progress and might open the door to some novel treatments for you and studies in the future should it be necessary. And that's free. So that'll get posted in the chat here in a minute or two, and that would be good for you.
Yeah, I'm trying to remember the name of this damn doc, this urologist at in Miami. I'm sorry. Really, the guy we need is probably Howard, because he knows who the urologists who don't push you into surgery are better than any of us, Mark. What's this guy's name? Okay, I'll put some stuff. Oh, well, the chat window doesn't do you any good because you're on the telephone, aren't you?
Oh.
Yeah, but I can get back on my computer just for some reason my microphone does not work, but I can get the information out of the chat.
No, you can't, because you won't see anything that isn't there already, or unless we pin it. So if we'd have to pin it, yeah, you might be able to.
Oh, so should I go and pin the survey?
Yeah, if you can see the survey, pin the survey, and I'm sorry, I'm a little bit discombobulated trying to get you this name, but I'll find it in a second.
Sure. No.
Well, let's open while you're checking, Rick. First of all, Sherelle, how did you hear about us? And do you have questions for the rest of the group?
I heard about y'all, some research I was doing. I saw y'all on the Mike Slive Foundation website.
Okay.
That's where I heard about AnCan and this group at. I don't know if y'all are familiar with that organization. Mike Slive, he was the former commissioner of the Southeast Conference, had prostate cancer, and created a foundation to combat prostate cancer, and that's where I saw the link for AnCan.
Well, I'm delighted that he knows about us. We're honored, aren't we?
And then do you have any questions for the group?
No. I don't have any questions for the group at this time. Y'all have given me some great information. I have a follow-up telehealth appointment on January 9th with UAB. They were wanted me to come back and saying, hey, what have I chosen? And of course, way too early to do that. I think my first step would be telling them I want to get a second opinion, and then going from there. But this has been very, very helpful to me in being able to ask the right questions.
Let me tell you one more thing that I've come across just in reading today, in that a person who has negative biopsies and then comes up with a positive usually has much less severe disease than someone who might get a first biopsy that is positive. So there's the fact that this took a while before they found it is interesting. There are other tests now. 4K is just one of them. The EpiSwitch PSE is another one. And this is not relevant to you, but it's another biomarker that I think may do a better job at getting rid of unnecessary biopsies and cutting down on those negative biopsies and getting the biopsies for people who more likely need treatment. Any comments from anybody else in the group? Let's see. Stuart, did you have your hand raised?
Yeah, Mark, should Sherelle ask for a decipher?
Absolutely, if that hasn't been done. Yeah. Are you familiar with this?
What's that I should ask for, Mark?
A decipher test, DECIPHER, and it's done on some of the tissue from the biopsy, and it predicts how likely this might be to spread. So it's certainly if the decipher test is significantly elevated, that too would tend to rule out the active surveillance if the decipher test is high. If it's very low, despite having the elevated PSA, you may discuss the active surveillance again. But also, I think it's going to be important to get those slides looked at by someone who just focuses on reading prostate slides. Stuart, did you have anything else on that you wanted to mention?
No, it's just because given his PSA, it might help determine whether or not ADT was recommended. It could help rule out ADT.
I think it certainly makes it an easier decision if that points one way or another. The important thing here is that you do have time. You should not feel forced or rushed to make a decision. At least with what we're hearing now, to spend 3 to 6 months to figure this out and do what's right for you is going to be most important. Rick.
So, Sherelle, the doctor that I was thinking of is Dr. Sanoj, Sanoj Punnen, Punnen. And it is pinned in the chat window if you sign on your computer. And you can do that at the same time, by the way, as your telephone, as long as you mute the computer, but you say your microphone is not working. I've also posted a link so that you can read about him. I think he might be, I'm pretty impressed with him. I think he might be a really good guy. I've also pinned Decipher test for you, so you'll find that. Have you signed up to get the reminders for this meeting and for our active surveillance meeting?
I have signed up for the reminders for this meeting, but not for the active surveillance.
Okay, well, you might want to add the active surveillance, only because you could be a candidate. The only thing that is preventing you right now is the level of your PSA, and that might go up and it might go down. And so you might pick up some information from those guys. They're not meeting this Wednesday because it's Christmas Day, but they are meeting on New Year's Day. So, you know, come in, talk to them as well.
Thank you.
Yeah.
I will do it.
Any other comments here for Sherelle? So once you get your PET scan result back and the second opinion on the pathology, and the second opinion on looking and evaluating options, come back and share it with us. We'd like to hear from you and see what you've decided or what directions you're leaning in.
I will do it. I plan on, as much as my schedule allows, to be a regular in this group.
Fantastic.
Hey, Sherelle, one other thing.
Yes.
If they did not give you the actual pathology, a copy of the actual pathology report, ask them for it. I hear these stories every now and then, with it basically the only thing you do is you get told it on the telephone, and you don't know, and you can't see the report, and you can't get them to explain it to you. I think that's really important.
I think
sir. I will do.
That's a good point, Stuart. And along with the pathology report, the MRI, on the latest MRI on a DVD that they used before the biopsy to indicate that you needed another biopsy. That would be helpful if you're going to Miami or going to deal with Dr. Punin.
Yes, sir.
Any other comments here? Rick, do you want to mention something about that JAMA article and what your thoughts are on, how badly this is really not anything that affects anybody who regularly attends low and intermediate, but it does suggest that one, we need to get to the right people and take some time doing that, and two, do the kinds of things we can to avoid being in that higher risk group.
Well, I will make some comments at the end, but I'm going to definitely pass the ball to Dr. John, because Dr. John has been leading the charge on how we at AnCan are going to respond, and in fact has drafted an email, which I still have to get to today because it's been a very crazy day, Dr. John. But, maybe you'd like to tell these guys what our concern is, and then I'll maybe make a comment at the end.
I already did, Rick, while you were next door in the other group.
Oh, okay.
This is when I mentioned that we had run across an article and a commentary on the article in a medical journal pointing out that docs were not keeping up with treatment intensification in people with metastatic prostate cancer, and speculating about why. And we wanted to lend our weight to that argument. So men with metastatic cancer can get what they need in terms of double drug therapy instead of just one.
That all got exacerbated this morning because we received an email from an MD who is part of this group, the low intermediate group, and was complaining that guidelines are not followed throughout all areas of medicine. Now, what made him bring up the topic of guidelines, I don't know, unless he had a super crystal ball and he was very psychic, because he doesn't even see the advanced reminder where we were just discussing this. He does see something we put into your reminder this week, which we ran in the advanced reminder a few weeks ago, which was an article in the Wall Street Journal that mentioned how difficult it is for people in rural areas to get appropriate treatment. And they have to travel a long way to find people that will treat them according to the guidelines very often. And I think that might have triggered him. I honestly don't know. I haven't heard back from him. But it was an even greater concern because this particular gent identified himself as a director of medicine for Blue Shield of California, which is a major payer. Payers are insurers. Payers just a general word for insurers. And as such, he said twice in this email that he sent to me that there was no evidence to add a second line anti-androgen. Now, that will be a foreign language to most of you on this call, but when most of you have heard of hormone therapy, and there are different levels of hormone therapy. And now, once your disease progresses, you very often get 2 lines of hormone therapy and not 1. And that's in most of the guidelines. And what this medical director told us, and he approves treatment for prostate cancer, is there was no evidence for this. There was some preliminary evidence in one study. Well, I would say if there's one study, there's probably 100 studies. And these studies have been going on since 2012. And there is a plethora of evidence about using more than one type of hormone therapy. And it gave me and Dr. John and Dr. Mark a lot of concern as to the level of knowledge that these MD medical directors have at the payers. And I actually also spoke to another doc who's in our other group, Dr. Alfredo, who was just totally dismayed and actually may have some contacts at Blue Shield. And what we realized is that we really have to do a much better job in educating the medical directors. It's not just our responsibility. I think it's also the responsibility of the pharmaceutical companies as well. And I will at some point reach out to a couple of contacts I have at the pharmaceutical companies and say, well, what are you doing about this? Because I have this letter and I'm going to share it with them.
What about ASCO?
Well, I'll be at GU ASCO and I will do what I can. I won't be at the main ASCO. But, some of it is credibility. AnCan has credibility not with the payers, but they have credibility with the providers. And they have credibility with many of the pharmaceutical companies. And all we can do is say, look, you've got to spend more money educating these payers. The problem is the payers don't want to listen. It's very easy saying educate somebody, but if the person that you want to educate doesn't want to be educated, you don't get too far. And frankly, these payers don't want to be educated. Why? Because the better they're educated, the more money they're going to have to spend. Better they should get shot in the back. So that's, I think, what Dr. Mark was alluding to. What I might have something to add on this, and I'm happy to if anybody's got opinions or thoughts on this. But it's a scary situation to me when a director of medicine for a major payer tells us, who approves these drugs, tells us there's no evidence when there's a huge amount of evidence.
Yeah, I wanted to comment back on the first part of that discussion. And I wish that article would have better defined the subgroups of physicians, rural versus city, university versus private practice. It wasn't clear to me. It's kind of like saying radiation therapy is good or radiation therapy is bad, to say that these problems were that physicians weren't educated. I think you need to know who it was and what type of practice setting, because I think rather than pointing to a single physician, it may be more important to look at the practice situation where we try to get care.
All
Um,
agreed.
Bob Weber, you signed in a little bit late. I wonder if you needed some time this evening.
No, I was just on here, Mark, just to listen tonight. It's been kind of a hectic 2 weeks since the last time I was on here, and I've had issues getting a hold of the doctor. I can't remember his name now. I'm sorry, I just blanked it. I had it here at University of Chicago. But I haven't been able to get through to get into an appointment. I sounds like I have to go through my primary physician in order to have him prescribed to him, for me to be prescribed to him.
Okay.
Well, is the Dr. Scott Eggener?
That's it, Dr. Scott. Yep.
Okay. Just to show you I was paying attention.
You were, Rick. Thank you.
Hey, Jonas, sorry to interrupt. Jonas, I just had a quick question for you. Did Dr. Nagar did prescribe any medications after the procedures, like for preventive, like Flomax or anything like that?
No. He just told me, I told him I was on one of the, not Flomax, the other one, and yeah, and he says use it as needed. You know, my urologist told me to stay on Flomax for.
But you had no significant side effects other than having to pee in the middle of the night or something like that. But other than that,
No.
major
I
side
mean
effects?
urination, some frequent urination here and there, but nothing too bad.
That's pretty much it. Okay. All right.
Yeah.
Enrico.
Thank you.
Enrico.
Yeah.
Dr. Nagar did put me. I was already on Flomax after my focal treatment, but Dr. Nagar wanted me to stay on it for at least 3 months after the treatment.
Okay. That sounds consistent with what I think you had mentioned to me. Okay. All right. Thank you.
Well, I think that that gets all the boxes checked that we had here. So if anybody has anything to say now or ask, now is the time to do that.
Now is the time.
Why don't you tell us a little bit about the ASCO meeting? I think I'm probably the only one besides you who might enjoy going to San Francisco.
Wait a minute. Wait a minute, because there might possibly be somebody else in this room who could be going to San Francisco, Dr. Mark.
Who besides you? John?
That was quite an introduction. Yeah, I'm already registered and I'm looking for plane tickets right now.
Fantastic. Are you going as an advocate or as a physician?
Well, I signed in as an advocate partly because I'll be accompanying Rick during a number of things, and partly because the registration is cheaper.
Yeah, it's a whole lot cheaper. I have to add up tomorrow. I have to add up the CME to see if I still need some hours.
Yeah, well, I doubt you can get CME hours as an advocate. That's the only thing.
I'm sure you can't, and I'm not sure where I would. Oh, emeritus member. Nope, I don't want that. That's $480 for emeritus. I can advocate just as well.
Let me explain that Dr. John is on a patient advisory board for an advanced protocol that one of our sponsors is developing. So they wanted him to come out and were willing to cover some expenses. And I at first thought, well, that's great because I'll just get a big room and we can share a room. And then I remembered it's Valentine's Day this year. I thought, I don't want to bring Dr. John away on Valentine's Day. Otherwise, his wife, Ray, will not be I will not be in her good books. So then Dr. John decided that maybe he and Ray could take a couple of days in San Francisco. And that's what's happening.
Well, that's what I thought. And that would be even better because your wife and my wife potentially could spend some time together.
Oh,
So,
yes.
Yeah.
Yes. And we may be able to get you some invitations if you do that, Dr. Mark. I don't know. But I will say, as far as the meeting is concerned, guys, the meeting, it's the genitourinary ASCO meeting. So it covers all genitourinary cancers, not just prostate cancer, bladder cancer, kidney cancer, and a couple of the other cancers on different days, testicular, etc. It covers all aspects. So it covers everything from pre-treatment active surveillance to advanced disease, surgery, and radiation, and everything, pretty much everything. They devote a day to each cancer, basically. So prostate's on the first day, and there's a plenary session with lots of interesting things discussed right the way through, including usually they have even something on active surveillance last year. In addition, there are a bunch of medical posters. There's probably a couple of hundred or more medical posters that you have to walk around, and we've actually exhibited a couple of times. So there's a lot going on, and then all of the pharmaceutical companies are there. So usually what I've done is I try to get into the presentations on the first day, and then on the second day, which is bladder cancer, I try to meet with all of my pharmaceutical companies and anybody else that I need to meet with, because there could be doctors and other people there to meet with. And that's sort of how it goes. And this year I'm going to have Dr. John as my wingman, which is fantastic. And maybe Dr. Mark as another wingman, which would be even better.
I won't bring Andrew, but
Well, then don't come.
Yeah. But I'll give you a call tomorrow if you're going to be around, and maybe get some more information about what your plans are, and then potentially take the train up the day before or fly up the day before, and spend the Thursday and that. I mean, one day would be great. It may even be worth paying for the CME. I'll just have to figure that out. So, okay, if that's it, and there are no more comments, wish everybody Merry Christmas, Happy Hanukkah, Happy New Year, and whatever else falls in the way.
And has everybody in here completed our survey? I hope so. If anybody has not completed the survey, do I need to put it in the chat window?
It's pinned at the top of the chat window.
Oh, it's pinned at the top of the chat. Thank you very much.
Yes.
Because we need you to complete the survey and also to look at us favorably, because this is our annual fundraising period. The only time in the year we ask you to consider helping us keep the doors open. So please consider helping us keep the doors open, especially if we've made a difference for your treatment this year and you appreciate what we do.
Good night, everyone.
Good night, all.
Good night, everybody.
Good night.